and welcome back to Mother Tongue, your eyes, ears and finger on the pulse for all parents around the world. Let's get going, shall we?
We are so incredibly excited to welcome Dr. Tina Williams to Mother Tongue. Dr. Tina, how are you? I feel like this is very bizarre seeing you on my screen instead of face to face with one of my many harem of children.
I'm fine. It's also nice to see you in this regard instead of seeing you as a mum. So.
That's very kind of you. I was actually, when I first saw you, I was like, what are the many things that I need to discuss with you today? Because obviously we're back in the newborn days and you forget how many questions you have for a paediatrician in those newborn days. I feel like my list is endless. I feel like I just need you on speed dial constantly so I can be like, this is just happening. What do we think about this? But yeah, I just think paediatricians in that first year of life especially are a godsend, and we are so incredibly lucky that we have the healthcare system that we have in this country, that it's so easy to see a paediatrician or get to the hospital, get to the doctors if we need to. But anyway, enough about me. Pediatrics is quite, I mean, it's not overly niche, but there's a journey to get into pediatrics. What was it that drew you to this field at the beginning?
Okay, pediatrics. So medicine, for some reason, all I remember was wanting to become a doctor from as young as as far back as 5-6 years. I'm not sure if my dad pushed me into it, but I always wanted to. And then I was good at sciences, so it just kind of followed naturally. The only other thing I thought of doing was engineering at one stage, but very quickly forgot about it because I don't like physics. But anyway, pediatrics in medical school kind of exposes you to different branches, and I loved children. I come from a huge family. I'm the first of 12, so I kind of did lots of looking after my younger siblings, and once I started working with children, I knew this was it.
Oh, I love that.
And I hated obstetrics. I hated the thought of women going into labor, so it was definitely not going to be that. I loved it, and I love helping children. I love children. They get better like that, and they don't pretend.
Yeah.
That they want to play.
Yeah. It's so true. It's so true. They are quite black and white most of the time, especially when they're small. And I mean, what does a typical day look like for you? I've always been so curious about this. I mean, you must see all sorts of weird cases, from children shoving stuff up their nose to, a common cold.
Okay, so a typical day for me, from start to finish, would be I'm kind of an empty nester now, so I have no responsibilities outside my job. So I wake up late, have a chilled 30 minutes, and I'm at work within an hour of waking up.
Oh, wow.
So life is good. So the only thing I do, apart from a quick prayer in the morning, is I would look at my messages at 7:30. I make sure I don't look at my phone before 7:30. And I get lots of messages from parents that have poured in from 6 a.m., which I do not look at because I've got to be disciplined. Look at them between 7:30 and 8, and answer a few, but some can wait. But once I get into work, it's outpatient, it's patient after patient after patient. I'm not sure if you're aware, but I don't do on-calls anymore. So most of my work is office pediatrics. That's a very American system. I don't do hospital pediatrics anymore, which is what I've always wanted. So I have a better relationship with my patients. I'm not stressed after a night on call. I come in fresh and we just talk. Coughs, colds, fevers, constipation, diarrhea, vomiting. What else do I see? Yeah, rashes. Rashes is a big thing.
Yeah.
But a lot of it is talking. Seeing the child is a few seconds. The rest is talking. And convincing the parents that actually they're fine, they're doing the right thing. You don't need to do anything more.
Yeah, it's so true. I feel like, especially as a first-time parent, a lot of what you do is probably talking those parents down off the ledge, as it were. Yeah, because those first few days, first few weeks, I mean, they are terrifying. And obviously, third time round, I've relaxed a little bit more into it. But, we had our little boy in A&E at 2 weeks old because his siblings decided to bring back home a virus from school. And you just never know you know, how babies are going to react at such a young age to when they catch these viruses. But we'll come on to viruses and illnesses because I do think it's such a big part of those, you know, that first year, really, because they're really building their immune system and everything else. But if we start in those first few days, obviously babies are born, we know what happens then. And then what are kind of the normal checkups that you as a pediatrician like to see in those kind of first couple of days and weeks?
Okay, I'm sure you remember that before you leave hospital, you get a baby check before you leave hospital.
Yeah.
Okay, so we're not talking about that, or do you want me to go through that as well?
Have a little go through that.
Okay. So basically, the pediatrician who sees you or the neonatologist in hospital is just trying to see that the baby's pooing, peeing all right and feeding well and hasn't lost too much weight.
Okay.
So obviously babies will lose some weight in the first few days of life, so they'll check the baby's weight at birth and then at discharge. And if the baby has lost anything more than 10% of its birth weight, your pediatrician gets a bit, or the neonatologist gets a bit anxious about feeding, pooing. And the color of the poo, we want it to be green to start with, and then it goes a bit yellow. So they check all those things, and then they check the baby from head to toe. Eyes, ears, mouth, looking for a cleft palate, the heart, and they check the saturations and a four-limb blood pressure, just to make sure there's nothing majorly wrong with the child's heart. That's the essential thing. And then you get that heel prick test.
Yes.
Done a newborn screening to make sure there's nothing that can be picked up, like a metabolic problem with thyroid issues, glucose metabolism, protein metabolism, fat metabolism, anything that might impact the child later is picked up. And you probably know that in the UAE we do a lot more than most other countries. Most countries will do what's called a Guthrie strip. So they take the same 4 drops of blood on a cardboard and send it off to a lab, and they check for thyroid, sickle cell, thalassemia, cystic fibrosis, and 1 or 2 other conditions. But the UAE do another 50-something conditions as well. So all those are tested for. You won't get the results for 2 weeks after anyway. But that's all part of what happens in the hospital before you leave. And of course, a jaundice check. So if the baby is jaundiced and there's yellowness on the white of the baby's eyes or the skin, they will do a jaundice check. In this country, they'll do the scan, the forehead scanner, but in other countries and in some hospitals, they'll actually take a blood spot to check.
Okay, interesting. And then what about vaccines? What vaccines happen in those kind of first few days?
Okay, so in this country, again, if we're talking specifically about the UAE, we tend to follow the American system very closely. So they give a hepatitis B at birth, and they offer a BCG as well.
Oh, wow.
Other countries don't necessarily do the same, and BCG is the vaccine against tuberculosis. That seems to be less of an issue than it was 20 years ago. So most countries do not give BCG at birth. But within the GCC, in Africa, in Asia, they still do. And
Okay.
as you know, Dubai is a mix of people from everywhere.
Yeah.
So it's worth getting it, even though a lot of parents are like, it's not given in the UK, I don't want it. No one will force them to have it. It's mandatory, but no one will stop you from not getting it. It doesn't actually stop you getting tuberculosis, but it means that if you do get tuberculosis, say from a nanny or from somebody visiting with tuberculosis, it's not as severe.
Okay.
I would not force it on any parent if they didn't want it.
And what about vitamin K?
So that's not a vaccine, that's just an injection to give what the baby doesn't produce enough of. It stops clotting, it ensures the baby clots, the blood clots. Otherwise, you end up oozing from the umbilicus.
Okay.
Or if you pierce the ears or do a circumcision, they bleed and bleed.
Oh, wow.
Vitamin K is something that's been given for years and years as an injection or as an oral medicine. Oral is obviously not well absorbed, and it's better to give it intramuscularly. But again, you have a lot of parents saying, no, baby's too young, I don't want anything. But I think vitamin K is not so much of a problem because most people know it needs to be given. If you don't,
Sure.
You stand up a chance of the baby bleeding and bleeding and bleeding.
Yeah, no, I actually never knew that. I've always said yes to vitamin K, but I've never known why.
Have you said yes to BCG? Did
Yes, I think I did. Because I'm quite pro vaccines in general. You know, I'm not like overly fixated on them. I don't have a massive opinion on them, but I am of the opinion that if they're going to help and prevent my baby from getting very sick or from dying, then I will take them. I'm also under the impression that these have been tested for years and years and years, and, you know, we all had them as kids, and I'm mostly totally fine. So, you know, I just assume that if we're being offered a vaccine, we should take it. And I've heard too many horrible stories of people not accepting vaccines and then their kids getting very sick and then dying, which, I mean, heaven forbid that ever happens. So, yeah, I would rather avoid that. But jaundice is an interesting one. Jaundice, I've never actually had a child who's had jaundice. Is jaundice something that newborns are born with? Is it something that they can then develop in the first few weeks or months? Like, how does jaundice work, and how can you heal or stop jaundice?
Okay, so jaundice means yellow eyes.
Yes.
Basically, and it's caused by a pigment called bilirubin. So that's what's tested on a blood test or on a forehead scan, bilirubin. So it's produced, it actually comes from the red blood cells. So when the red blood cells break, they release bilirubin into the system, into the bloodstream, and your liver is supposed to get rid of it.
Okay.
Normal process. Babies are born with livers that are not very mature, and if there's lots of red cells to break down, I'll explain why. If there's a lot of red cells to break down, they release even more bilirubin, and the liver is not mature enough to manage it. So the liver ends up not being able to get rid of all that bilirubin, and it ends up being deposited on the skin, the whites of the eyes, and in the bloodstream. And sometimes, if it's high enough, if the level is high enough, it seeps into the brain, which we don't want.
No.
But actually, it's normal. We call it physiological jaundice. If you notice the yellowness from after 48 hours, because that's normal. The baby is born with a lot of red blood cells because in the womb it needs a lot of red cells to carry oxygen. But once the baby comes out, it doesn't need that anymore because it breathes in oxygen and it's pink. So the body says, I don't need all these red blood cells, let's get rid of them. So they end up being broken down and peed out, basically. So a baby that's feeding well, that's otherwise well, should be able to pee out most of that bilirubin. And there will be some yellowness, but not much. I'm surprised yours have never had it. There's not many children who don't have jaundice. Sometimes it's quite mild, and maybe you haven't noticed it. It's quite common. I'd say 70 to 80% of children will have jaundice.
Okay.
Normal jaundice. Then you have the pathological or not normal jaundice that goes above the level that we call a danger line. So
okay.
If it goes above a certain line, then they end up having to be readmitted and going under the phototherapy lights to clear out the jaundice. Or even worse, they get even more. They need an exchange transfusion. You take out their blood and replace it, and you give them some immunoglobulins. It can get complicated, but generally, if that happens, then there's something else going on. So they're septic, they've got some infection, or there's a blood group incompatibility.
Okay, interesting. Yeah, so we, as far as I'm aware, they would never, I've never been told that any of them had jaundice, but we always had issues with sugar levels, blood sugar levels. So they've all come out with, I think it was low blood sugar levels. So because they've all been really, really big babies, they've all had exactly the same issue. So now I kind of know what to expect. And my milk normally takes quite a long time to come in, so they've all been on formula through a flow cup in the first 24 hours of life, sometimes longer. Rafa's was the worst, and I think Rocco's was the best of all of them. But yeah, it's very interesting. And I remember when they first told us about it, I was like, oh my God, what's happening? What's going on? They were like, no, don't worry. It's quite normal. So yeah, if you are also in a similar situation to that, definitely do not panic. I wanted to move on to rashes, newborn rashes. Now, there is, I feel like skin issues still now. I mean, Rocco, I feel like I harp on about this all the time on the podcast, but Rocco is, I'm pretty sure, like 99% sure he's got CMPA. But because he's got laryngoscope.
Malaysia.
Thank you.
Floppy larynx.
Yeah. He struggles. Anything that's really thin, it makes his reflux really, really bad, and he chokes a lot. But he has quite bad skin issues, and it's a reaction of the CMPA. That is my understanding anyway. And you can kind of tell, like, it's almost like the top layer of his skin is quite smooth from the amount I'm moisturizing him, but you can kind of feel the underneath bit that it's kind of coming out from the skin as opposed to being a worrying rash. But there are lots of kids have rash and eczema and all sorts of things in the early days when they're adjusting to the outside world. Can you just tell me the difference between what is considered a normal rash versus something that is worrying?
Okay, so normal rashes, some babies have no rashes at all. Very lucky. But baby acne, I'm sure that rings bells.
Definitely.
Yeah, and those look like little pimples, generally on the face, on the extremities as well, and they come and go. They can look really ugly and scary. Because if you see the pictures, if you Google baby acne, you see some really ugly pictures, and it looks like they're all over, and you can understand the parents when they panic. But actually, the baby's fine. Baby's got no fever, baby's feeding well. The only thing is the ugly looking rash. It's not itchy, the baby's happy feeding as normal. And as scary as it sounds, we generally say do nothing. Just don't do anything that will irritate the rash and make it worse. So keep them cool, use just water to clean their faces, avoid moisturizers or anything like that. So that's the commonest normal rash you'll get. You'll get dry skin as well. Especially if you overbathe the child, they will get dry skin, and then you get the normal peeling that they do in the first week or two of life. So you don't always need to treat that. Sometimes parents jump in and want to moisturize, and then you end up having the problems with irritated skin. It gets red, it gets sore, the dryness gets even 10 times worse. So we try and keep it simple. I would say in the first month, if you can stick to just water in the bath, that's fine, and no moisturizer. Unless they're getting drier and drier, then go for, there's lots of hypoallergenic, non-perfumed emollients or moisturizers out there. I don't need to name the names, but I'm sure we know Mastella, Cetaphil, QV, there's lots of them. Cream outside here, Diprobase, there are lots of things you can use, but only if needed. If not, don't bother.
Okay, this is good to know. Another thing that I've actually found is really helped is putting coconut oil in the bath. So we again, I mean, I want to come back onto your thoughts on bathing in those early days, but coconut oil in the bath and then coconut oil on the skin afterwards has helped a little bit.
So it helps for some, but I find that for some, coconut oil actually makes things worse.
Oh, really?
So most of the, even, do you know aqueous cream? Does that ring any bells?
No.
Okay. It's a very UK or South African moisturizer. So if you have dry skin, you'll be recommended to use aqueous cream or a moisturizer or a soap alternative. It's called a soap substitute in the bath. So you're putting coconut oil in the bath is actually just using water and making sure after you clean them, the oil just sticks. So that's all you're trying to do. Let the oil stick onto the skin. So when it comes out of the bath, you shouldn't wipe him dry. You should dab him. So you're getting off the residual water, but not taking off oil.
Okay.
Keep some moisture to sink into the skin and then moisturizing. So your coconut oil on top is kind of trapping in the moisture.
Okay.
White soaps. Soaps always make things worse because soap will dry the skin.
Yes.
So Mastella, Cetaphil, QV, La Roche, whichever one you use, the wash is not actually soapy. So we take off the baby's oil.
Okay.
So
Good to know.
Baths.
Minimize bath.
Yeah, 2 or 3 times a week. Enough.
Even at this age?
It depends on his skin, but the way you're describing his skin, it sounds like he could do with few baths, not too. I mean, he's not dirty, is he?
Well, you say this, Dr. Tina. He's a vomiter. I mean, I'm talking like 10 times a day. He's sick on himself.
So then you just use water to clean that off.
Okay.
So try not to wash it off. Just rinse it off.
Or wipe it?
If you wipe it, you're wiping off his oil, and that's the protective layer. That traps in moisture. So any wiping will take off oil.
Okay.
Wipe him, then you apply more. You can apply moisturizer 10 times a day.
Okay.
Harmless.
Okay. Okay. And then what about those early days? How often should we be bathing babies in those really early days? I mean, I don't think I bathed Rocco for, apart from that first bath in the hospital, I think he got a bath every 2 weeks for about 6 weeks.
That is perfect. That is
Okay.
perfect. Even the first bath in the hospital, I always query why they do it.
Yeah.
I wonder if they do it just to show you how to do a bath, but they don't need a bath. They've got vernix, which keeps them moist, which keeps them healthy. They don't need any baths.
Okay, this is good to know because I've always, I mean, yeah, I don't know why I've always accepted that bath in the hospital, to be honest, because especially this time round, I was like, let's keep all this nice gooey stuff on you.
It's
'Cause-
oil.
Okay, so yeah, I was going to say, what is all of that stuff and why is it so good for babies to keep it on?
Because it's oil and it contains some antibodies as well, so it prevents the skin getting infected, it traps in moisture, stops dry skin, so you don't need to take it off.
Okay.
Even in little girls, and you know this because you've got one, and when you're cleaning them down below, parents are scared to clean in between the folds, but you can actually clean if there's poo there. But if there's no poo there and it's not gone yellow, leave the white stuff there. It's there as a layer as a protective layer. It's like your barrier cream.
Okay.
Don't take it off. Leave it.
Okay, this is good. Good fact of the day. And then Tina, when do you normally see babies post-hospital? So they come home and then when is the first check?
The first check, it used to be, and I refer to what we used to do at Mediclinic Parkview, we fought against it, and we like to see them within the first week.
Okay.
Because we want to make sure they've not lost lots of weight.
Okay.
Make sure they're feeding well. And if they're jaundiced, make sure they're not too jaundiced. So the first week is safe. If you wait for 2 weeks, like some hospitals do, lots happens in the first 2 weeks. If they're not gaining weight, if they're not pooing, not passing urine, they'll dehydrate and get sick. So the earlier, the better. Just one check, and that's it.
And talk to me about weight gain. We know it's extremely common. In fact, I think it's the norm that babies always lose weight post-birth. What is considered like a quite a bad weight loss, and what are we expecting in terms of like regaining back to birth weight? How many weeks after the baby's born?
Okay, so we expect them to lose up to 10% of their birth weight. Remember,
Okay.
10% could be 10.5, 11, 8.5. So we're a little bit flexible, but 10% is that number, that magic number that we look at. We expect them to lose that within the first 4 or 5 days, because that's how long it takes for, if you're a breastfeeding mum, that's how long it takes for milk to start coming out.
Okay.
Some people are lucky and within 48 hours they can produce gallons, they can even express, but that's unusual.
Yeah, that's not me.
That's not most women. There are very few that do it. And if you're giving formula, of course, from day one, then, you know, they don't even lose weight. Some babies do not lose weight. Some babies do not lose weight. But what we expect is not more than 10% within the first 3-4 days of life. If they leave hospital and have lost 10% already, they'll get an appointment very quickly. Within
Okay.
8 days.
Okay.
We expect them to regain by between 10 and 14 days. But
Okay.
then if they're bottle fed, formula fed, or if mum has a lot of milk, you know, before then they would have regained their birth weight. And when we see them, we just want to make sure if they're still losing weight, they haven't lost too much, they're passing urine, they're not dehydrated, because if they're dehydrated, you start noticing those pink crystals in their nappies. You probably, does that ring any bells? Okay.
No.
So a lot of parents will say they could see blood in the nappy, and it's not actually blood, it's pink. They're crystals. They're called urate crystals. So if
Wow.
you're a little dehydrated, there's a pink patch, usually in front. Different to what you see in baby girls, because they can have mini periods. You know, they can have blood and mucus. Okay, you obviously didn't expect that.
No.
So girls can have blood and mucus as a result of withdrawing from mum's hormones in their bloodstream. But that's
Wow.
different. That looks like blood and mucus.
Okay.
Yeah. But if they're dehydrated, they have pink or orange crystals in their nappies.
So
Then we know
interesting.
they need more fluids.
Wow.
It doesn't always have to be formula. You can also get the mum to pump or to express and top up with the flow cup or with the bottle, whatever suits her.
Wow.
Much
So
like
interesting.
we love baby friendly, we like breast milk, but it's important that the baby doesn't get dehydrated and that mom is not stressing so much
No,
about
no.
feeding that she's going crazy. So
Yeah.
offer a bottle if necessary.
Yeah, no, to be honest, I mean, I was adamant with my first that he would be exclusively breastfed, and then he was allergic to my breast milk. So after making this massive supply, I then had to stop entirely. And I remember vividly, he started sleeping through the night, and I was still getting up in the middle of the night to pump because I couldn't get through a night without my boobs just exploding. It was horrid. And I was like, what is this? This is so frustrating. Why have I done this to myself? Ooh. Anyway, I wanted to move on to illnesses and vaccines because illnesses, especially this time round, it's been quite new territory for me. And I know that especially mums who might be, that they might have an older child at home and they're bringing home a baby, illnesses get passed around, especially this year. I feel like this winter has been particularly bad in Dubai with influenza A, RSV, strep. There's been so much. Now, when a baby gets a fever, when should we worry versus when are we okay to manage it at home? And also, when is that the real danger period? Because I remember like Rocco was 2 weeks and that felt quite scary. But now he had a fever a couple of weeks ago and he got up to about 38, but he's now nearly 4 months. And I was like, we're okay now. We can manage this at home. Can you just tell us, when we should be on high alert versus when we shouldn't?
Yes, the scary period is 2 months and below. That's
Okay.
the most scary because their immune systems are not well developed. You just do not know. They don't always have fevers. They may just be lethargic and not feeding, and that's all it is. But we worry about sepsis.
Okay.
So they can get really sick. So below 2 months and below, if they have a fever, definitely take them in. Even if the siblings have a cough or cold and you think it's likely the same thing, just don't risk it. 2 months and below, get them seen.
Okay, so sepsis, is sepsis something that they can catch from a sibling, or is it something that they might have got at birth and it's just developed?
Both.
Okay.
So one, yes, you know about group B strep, so moms get swabbed when
Yes.
they're pregnant for group B. So you can have a late onset group B strep sepsis that can present at a month of age or even later. So we don't want to just assume it's because the sibling, say because older siblings or Rafa has a cold, that's why Rocco's got a fever. Now it may be something else. It may be group B strep. So we'd always think sepsis and then other infections.
Okay, and what are the main markers for these? What are the main telltale signs that they might have this?
Fevers, not feeding well.
Okay.
And
Okay.
listlessness or just not handling as normal. So moms would know something's not right. This is different. Baby feeding and fever.
Okay.
Yeah. And
And-
obviously breathing difficulties as well. So if they're breathing fast or indrawing their chest, and I think did Rocco do that as well?
Yeah.
Right.
Yeah.
Struggling to breathe or breathing very fast, indrawing chest walls, worrying signs. Just it's not worth taking the risk. And luckily in Dubai, you have very easy, ready access to hospitals, to emergencies, there's pediatricians. So don't mess around.
No, I agree with that. And I remember when he was sick, he was unlike elder children, when your newborn has a fever, the fever gauge is quite different. You wouldn't wait until they got to 39. When is kind of like, for them to hit a certain mark, like when is that worrying? We're talking about 38, 37.5?
Again, it depends on your baby. So a fever technically is 38, but if a baby was 37.8, I would still worry. 2 months
Okay.
or below. I would
Okay.
still worry because something's starting. And some
Okay.
of them are hypothermic, so they go cold. They could be 35 when they're sick and septic. So anything that doesn't feel right with the baby, don't joke about.
Okay.
Once they're over 2 months, so between 2 months and 6 months, you can relax a little bit. But obviously they're still under 6 months. So if they have high fevers that you cannot control, they're not feeding well, there's no obvious reason for the fever, take them in.
Okay.
Then there's urine infections as well. Newborns can have urine infections, no signs at all. They can't tell you it stings when they pee. So all you have is a fever, or they're not feeding well, or they're losing weight.
Okay, this is good to know. And what about medication? So if, let's say, we've got a 2 to 6 month old child and they're presenting a fever of 38, let's call it, would you advise, again, we go and see a doctor, or are we okay to kind of get the recommended dose of Calpol or ibuprofen? I mean, in our children, ibuprofen has always worked so much better than Calpol in terms of bringing fevers down. But would you also recommend going to see a doctor at this point?
You can give ibuprofen, obviously, or paracetamol. I prefer paracetamol, or Calpol, or Adol, or Panadol, whichever brand you use. I prefer paracetamol. And if you couldn't get it down with paracetamol, then move on to Brufen.
Okay.
As they get older, ibuprofen is fine to use as and when, but the younger they are, we tend to prefer the milder antipyretics or anti-fever medicines. So paracetamol. Obviously, give them the fever medicines. If they're behaving normally and all they've got is a low-grade temperature, they've got a runny nose, and they're breathing okay, they're feeding okay, then manage them at home. That's the older ones. That's between 2 and 6. But the minute something doesn't seem right, you can't
take them in.
Fever down, take them in.
Yeah. Then I wanted to touch on RSV, because my middle daughter, I'm sure you remember, she had RSV at 5 weeks. And RSV is very, very common, especially in younger children. And I know that there's now this vaccine that's going around that you can get when you're pregnant. And I actually very much opted for that this time round, because once you've had a small baby go through RSV, you don't hesitate. But RSV has a really long life in a child. And I remember she was quite unwell for about 10 days. RSV, bronchitis, all these kind of illnesses that hit the chest and hit the breathing. What are the signs that this might be coming on, and how can we react to this? Because again, you can't take antibiotics or anything for these sorts of things.
They're viral, and it really depends, because you have no way of knowing which virus it is, whether it's RSV or just a common cold, until it spreads down and they start having difficulties in breathing. I think as a medical person, you know the sound of the cough. So RSV coughs have a particular sound. It's a very fine, crackly sound. It doesn't sound like you can scoop out the mucus. It just has that crackling when they cough. And they cough, and they get really distressed by it. So that's how I can guess it's RSV. We don't necessarily test for it. We just go by the symptoms. But again, the younger they are, the number of risk factors they have. So if they were born preterm, prematurely, so before 36 weeks, or if they had any respiratory problems on the newborn unit, or if they had heart problems, they tend to get sicker with RSV. So if they have none of those, then most babies, I'd say more than 50%, get through RSV without seeing the hospital at all.
Okay.
Yes, but some do get quite ill, needing to be admitted, oxygen, intravenous fluids, may even need ventilation as well.
Yeah, it is terrifying. It is terrifying.
Just look out for feeding again, fever, and breathing.
And again,
Feeding and breathing.
things like RSV and bronchitis and any other kind of chest infections. Now, this might be a coincidence. It might be linked. I always think that it's linked. But, our daughter now, every single time she gets a cold or anything, it hits her chest, always. And she seems to have some form of asthma, difficulty breathing. And she coughs the entire time. I think we might have the odd week a year where she's not coughing. And it varies from being quite bad to fair. But can these respiratory issues that they get in these early days cause things like asthma and coughing issues down the line?
Yes, they can. So RSV is well known that for about a year, sometimes a bit more after RSV, you have scarring. I'd call it scarring. That's the best way to describe it, within the walls of the bronchioles, so that every time you get a cold, you behave like you've got asthma and you wheeze or you cough for a long time. But it should that should stop after about a year, maximum 2 years.
Okay.
There's a medical term for it. It's called bronchiolitis obliterans, which means your bronchioles are narrower almost blocked. So it's very easy to block off and start wheezing. But again, it may be that she just has childhood asthma.
Yeah.
And grew out of it.
Yeah.
Who knows?
It doesn't seem to affect her.
What did Rocco have at 2 weeks? It wasn't RSV, was it?
No, he had a virus. It was a virus that came through the house. No one ever really knew what it was, but we all had it. He was the last to get it.
And did you take the RSV vaccine when you were pregnant?
Yeah.
Okay, so it may even have been RSV, and the vaccine that you had protected him.
Yeah.
So he could catch the virus, but not be severe enough.
Which was good. Thank God.
And
Thank
actually,
God.
incidentally, I was in Canada a few months ago, and my nephew was born, and he was given the RSV vaccine because they give it to they've got the one that's given to the babies. So
Wow.
Rolling it out this winter, and the midwives were saying they've already seen a difference. They've not seen any RSVs, so they're giving the babies the RSV vaccine before they leave hospital.
That's amazing.
They have older siblings at home.
That's amazing. Because that comes into my next question. I mean, again, if you are a parent and you have elder siblings and a newborn at home, it's almost impossible to protect them from other viruses because schools seem to be a breeding ground. Kids go on holidays. You know, when the holidays come, they go away, they come back, they bring all the viruses back into the country. And as we know, small kids are obsessed with babies. Obsessed. I mean, Isla basically licks Rocco's face daily. I mean, she's like right up in it, and I've given up now. I'm a bit like, I can't help it. You know, she shoves her fingers in his mouth. She does everything. I mean, how can we protect the newborns from their elder siblings, the super spreaders?
It's almost impossible. But
Yeah.
I usually tell pregnant mums to start when you train the baby to know that the baby train the older sibling to kiss the feet rather than the baby's mouth or the baby's nose or the baby's face as much as possible. It doesn't always work because you can't kiss either. Because if the older sibling sees you kissing the baby's cheeks, he wants to kiss the baby's cheeks as well. So what can you do? And once they have a cold and cough, you can't put a mask on them either. So you only do your best. If you catch a cold as a mother, wear a mask when you're feeding, when you're breastfeeding, because you'll have the closest contact. So that's the best you can do.
Yeah.
As much you can do.
And I mean,
mine got a cold, her first cold at 2 weeks from her sibling. I was prepared for it. I just sat up all night, and we survived it.
Yeah.
Luckily, it wasn't RSV.
Yeah, that's good. I mean, that's the thing. All I'm saying to myself is Rocket's going to have a great immune system. Hopefully. Fingers crossed.
And hopefully he doesn't end up with the cough and the wheeziness that his sister has.
No, do you know what? He is quite mucousy behind his nose, but again, it's the CMPA. He hasn't really since he was unwell, touch wood, he hasn't really coughed or anything since, which has been good. I wanted to touch upon cold sores. Now, cold sores, I remember a very long time ago seeing a story. It was actually on Annabelle Carmel's Instagram, and she had a little baby who was kissed by someone who had a cold sore, and then really sadly the baby died. Can you tell us the link between cold sores and what they pass over to babies, and how cold sores can be really dangerous for small children?
Yes, remembering that babies, especially under 6 months, their immune systems are not as developed as older children. So if you have a cold sore, which means you've had it's something you've had dormant, you've got the virus in you and it's been dormant for a long time, so you're stressed or you're not feeling very well, and then it pops up. You've actually got the active virus there. So kissing the baby will pass on the virus to the baby, and then the baby can get very ill from it. It can spread through the bloodstream to the brain, and they get really sick. I must say I haven't seen many cases. It's more common it's not very common, maybe because people are more aware and they cover the cold sore, but it doesn't happen much, but it does happen. I have lots of mums who panic because they've kissed the baby's head, but you need to be quite close to the baby's nose, mouth or eyes to pass it on, because it will go through the mucosa. If you kiss the baby's scalp, it's not going to. Nothing's going to happen. But obviously it's a risk, and if you have friends who've got cold sores, most people know.
Yeah.
It's not something that happens often these days at all.
And the danger zone of that period. So let's say, because I asked this because my husband gets cold sores quite often, especially when he's stressed, and I've always been hyper vigilant about it. You know, when they kind of get past the 4, 5, 6 month phase, is it less risky?
It is less dangerous because the baby has a bit of a better immune system. They do have immune systems. They're not born without. They obviously, we give them vaccines, so that means we're trying to trigger the immune systems, and we depend on the immune systems working to respond to the vaccines. So, but above 6 months, even better. The older the baby is, the better.
Okay.
But I think we're parents, we're mothers, we will worry even for a 5-year-old. But
Oh, God.
what? I've seen 4 or 5-year-olds with cold sores. Unlucky, but yes, I have seen some.
I wanted to touch upon vaccines now. Now the first year of life, you get a lot of vaccines. What are the most important vaccines? Because I know that there are lots here that are not necessarily mandatory, but they're very much suggested. They're covered by insurance. But there are lots of vaccines that are kind of offered but not covered. Which are the ones that you would really say are important that we don't miss?
So if we're talking Dubai specifically,
Yeah.
the mandatory ones in Dubai are mandatory all over the world.
Okay.
So a few years ago, I'd say maybe 20 years ago, some parts of Europe would not give the rotavirus, would not give hepatitis B, but right now, across the board, you've got the same mandatory vaccines everywhere. Europe, Australia, Canada will add some extra ones for meningococcal disease or meningitis,
Yeah.
meningitis B, meningitis C, because they're still prevalent there.
Okay.
The UAE is not mandating it yet, but Saudi Arabia, just down the road, it's mandatory there.
Okay.
Other countries within the GCC are giving meningitis vaccines as mandatory as well.
Okay.
So there's slight differences, but the ones that you don't want to get are the ones that you cannot treat. Polio.
Okay.
Tetanus,
Yeah.
you can't treat them. So if you get polio, there's no treatment. You end up paralyzed in some way, shape, or form. Tetanus kills you. There is no treatment for it. And then you've got the nasty bacterial things like pneumococcus, which gives you pneumonias, meningitis. You've got Haemophilus that gives you respiratory infections. You've got, what else? So diphtheria, whooping cough, and diphtheria are also bacterial infections as well. So I would say, because I have a lot of parents who are hesitant to give the vaccines and they want to know a lot about the vaccines, I usually tell them at least give them your diphtheria, whooping cough, tetanus, polio, and Haemophilus, as well as the pneumococcal.
Okay.
So you know there's a 6-in-1 vaccine?
Yeah.
That contains hepatitis B as well.
Okay.
Recently, a lot of parents have been saying, why do I need hepatitis B? It's transmitted through bodily fluids. My child is not going to have contact with bodily fluids till they're older teenagers or adults. So why do I need it? And people are refusing it. You can't force parents. So if they refuse, we may remove the hepatitis B and give them the 5-in-1 instead.
Yeah.
But all those, the diphtheria, whooping cough, tetanus, polio, and Haemophilus, essential. And then the other injection is the pneumococcal. That is pneumococcal pneumonia, pneumococcal meningitis, definitely.
Okay.
Rotavirus is the oral one, which, some children cannot get the vaccine because their mums are on certain medications and are breastfeeding, so they don't get it. So it's not the end of the world if you say no to rotavirus.
Mm-hmm.
Those big ones definitely take.
Definitely don't bypass.
And if you live in the UK, you live in Australia, you live in Canada, Turkey, you can't say no to the meningitis ones.
Yeah.
You travel once or twice a year to family where you're likely to get meningitis.
Don't take the risk.
Don't take the risk.
No.
I trained in the UK, and I remember this was going on about 20 years ago. Every night, there was a case of meningococcal sepsis. It was horrible.
Oh, God.
The last test, the non-blanching rash spreading before your eyes, and they lose fingers. It is horrible.
When do we get the meningitis jabs, meningococcal?
In this country, it's not mandatory. So
No, but when do you offer them?
2 months, 4 months,
Okay.
and then at 12 months.
Okay. I think we've already had ours then. Thank God.
You're
Thank
very
God.
pro-vaccine, so
I'm literally like, give me them all. Give me them all.
good for you. I think that's the best thing. I think, again, the younger generation of parents have not seen polio, have not seen tetanus, but I have seen them. And it's scary. It's really scary.
Yeah, it is. It is.
MMR issue, the MMR vaccine and the possible association with autism. I'd rather have a live child with autism than a dead child. So I wouldn't joke about vaccines at all.
No, no. My final question for you is actually very much related to where we are at the moment. Lots of people in this part of the world talk about the pollution, the air quality, living with humidifiers and purifiers in every single room, which, to be fair, I mean, I kind of do that. Now, do you think we're putting our kids at risk of getting more kind of chest infections or developing issues with their respiratory system later in life by living in a country that is very dusty and has lots of pollution?
I do think we have a lot of dust, and there's no way you breathe in dust or mold, because there's mold in houses as well, and it won't be deposited in your lungs. The question is, what does the future hold? We don't know. We don't know. How the UAE is a relatively young country.
Yeah.
So how long it's maybe about 30 years. So we don't know is the answer to that. So I would say yes, if you can afford to have an air purifier in the house, perfect. But the children go out, they go to school, so they're exposed to the same insults there. And it's difficult. I have had parents leave the country because they've looked at their pollution index and they're like, no way. But at the end of the day, it's all a balance. All a balance.
Yeah.
Do your best. That's all you can do.
Yeah. And to be honest, a lot of people, there is this big debate at the moment if it's actually pollution versus is it just dust. Because I don't think the UAE is an overly polluted country. I could be wrong here. I mean, I don't particularly look into all this stuff a great deal. But from what I see, when the app's saying that the pollution is really bad, it's normally a sandstorm. Am I right?
It is. And there's lots of building works as well. So you've got the cement, all dust particles.
Dust. And apart from purifiers, any tips on how we can avoid it?
Live somewhere, there's nowhere, because there's building works everywhere. There's sand all over us, so you can't do much.
You can't do much. Okay, well, this is good to know. And my final question for you before we go on to tips and products. If we want to support our children's immune system, is there anything that we can do? Anything that we can give them? Probiotics, vitamins? What are your thoughts on all of this?
Okay, the only thing that we have evidence for that works for the immune system is vitamin D.
Okay.
During the COVID time as well, we were trying to boost vitamin D levels to help people get over COVID. So vitamin D levels, especially in the UAE, we don't spend enough time in the sun, so almost all of us are low on vitamin D. So make sure the children are on daily vitamin D.
Okay.
Minimum between 400 and 600 units every day. Whether it's part of a multivitamin or on its own, give them vitamin D.
Okay.
All the other products like echinacea, Kinder Immune, what else? Manuka honey. There's no real evidence for them.
Okay.
Probiotics. There's no real evidence that it boosts your immune system. But look, whatever works for you, as long as you're doing no harm, I wouldn't say no.
Okay. This moves us quite nicely onto tips and products. Dr. Tina, if you were to leave us with one tip and one product, what would they be?
Okay, tip. Don't worry about fevers. Fevers don't do any harm to children. They're actually good. It's a way of the immune system fighting. It just shows that the immune system is fighting whatever the infection is. But the main tip I'm trying to bring out is if your child has a fever that comes down when you give antipyretics, which is paracetamol or ibuprofen, then you don't need to worry.
Okay.
A fever that doesn't come down with your the correct dose of your antipyretics is more worrying than a fever that comes down and then goes back up again. That's what fevers do. They go up and down. So top tip there is don't worry about a fever unless you can't get it down or it's gone on for longer than 2-3 days or your child looks unwell.
Okay.
Otherwise, 9 times out of 10, it's going to be a virus.
And they're just fighting it.
Yes, and if you're worried and you go to the doctor day 0 and they do swabs, they'll all be negative. So there's no sense panicking and going so early. Manage the fever and watch your child. You know your child best. And you stand a higher chance of being given antibiotics unnecessarily if you're worried and you're panicking.
Okay.
And you get blood tests, swabs, and everything you can think of. So try and manage it at home. And you're an experienced mum, so you're less worried as the more children you get. So you know.
For sure.
The signs.
For sure. And then what about a product? Top product for us, Dr. Tina.
Top product for me is pseudocream. Pseudocream or a barrier cream. And that's for babies. I'm not sure if it's right, but for mine, from day 1, I just covered them in pseudocream because I did not want to deal with nappy rashes. And they sleep for hours overnight. You can't change their nappies overnight. So cover them in a barrier cream. And then for older girls, especially, once they start cleaning themselves in school, in nursery, they don't clean properly. They end up getting vulvitis, sore vulval areas, and you're wondering, is it urinary tract infection or not? Pseudocream works. After staycations, after bubble baths, and you've rinsed them off with water, pseudocream.
Okay.
Saver, and I kept it. I have 2 girls, so we had pseudocream with us everywhere till they went into puberty, and then we got rid of pseudocream. Okay,
this is a good tip because I don't do that.
You only have 1 girl. It's fine. It may come. But actually, pseudocream, bepanthen, metanium, they're all barrier creams. Just like pseudocream sticks, so you don't have to keep reapplying and reapplying.
Okay, this is good to know. And then, Tina, for anyone who wants to reach out, find you, come and visit you, where can they find you?
I work at Mediclinic, Parkview Hospital and Miaisem. I hope I pronounced it right, but I mean either place.
Perfect. I'm going to link all of this in the show notes. And I must also say that Dr. Tina is also our doctor and has been for a long time now. I think since Rafa was really small, right?
Was it more for Isla?
Maybe it was for Isla. I don't remember. Honestly, it's all kind of just blends into one now. Well, Tina, you have been absolutely fabulous. Thank you so much for your time today. We really appreciate it. So many words of wisdom that I'm going to be taking away. And hopefully we'll be seeing you again soon. Right, just